All right. Well, and welcome everybody. We're delighted to have speaking with us this morning, Dr. Tod Wyn, uh, special person in my life. He was actually the first person to be trained in an HPM fellowship here in Grand Rapids, and has been in the area for the last dozen years since he graduated. And we're just thrilled and proud to have you representing our community in this program, and has been wonderful to continue serving our community with his lectures and his presence and just the great work you do in Holland.
Well, thank you, John, and right back at you. A special person in my life as well. That was an important career change for me that happened a long time ago, and it's been a good field to be working in. So nice to see all you guys here, and all of you joining us on Zoom. Welcome. So I'm giving a lecture today on treatment for nausea and vomiting. This is a talk I've done several times over the years. I was doing in preparation for the lecture this year. I was doing another Google search trying to see what new things are out there, and I didn't find a whole lot of new things. The talk feels a little dated to me in some ways, but one thing I'll be asking for you guys as participants is to chime in when you have your own experience with either a different regimen or a different medication or different thoughts on how to approach this sometimes complicated symptom management challenge for us. So just to please chime in.
Yeah, I just want, as a prelude, and this is for the fellows. So this is what we charged Tod with putting together while he was a fellow. We all do these talks. You're preparing your talks for end of the year, and Tod did his talk on nausea, vomiting. It was very, very good. And so we took him to a state meeting where he presented that, and it also went off very well. I still have that PowerPoint, and I was looking at it, comparing it. It really has evolved. You've done a nice job keeping it updated, even though people still puke, and so I don't know if that's we're going to change. So,
right.
But anyway, so just keep in mind that whatever you do may have lasting significance, and you may find yourself in that seat here years from now.
Well, we'll hope so. Good. So let's see here, John. I'm not advancing.
Okay, let me just. That should be triggered to.
Okay. So disclosures, no financial disclosures, and we are going to be talking about off-label use of medications, as is, I think, very common in these palliative care lectures yet. Objectives today, we want you to be able to identify the mechanisms involved in nausea and the various triggers that will induce nausea and vomiting. Identify the various treatments and remedies for nausea and the specific indications for their use. And then we'll give to a couple of notable quotations. So Josh Billings back in the 1860s says, one of the best temporary cures for pride and affectation is seasickness. A man who wants to vomit never puts on airs. It's a great equalizer in terms of symptomatology. It's hard to be arrogant when you're hurling. The act of vomiting deserves your respect. It's an orchestral event of the gut. I love that sentence. It's an orchestral event of the gut. It speaks to the complicated triggers for it and the neurologically complicated pathways for initiating nausea and vomiting. And then Rodney Dangerfield, for those of us who are older.
Absolutely.
I went to see my doctor. Yeah, I told him, doctor, every morning when I get up and look in the mirror, I feel like throwing up. What's wrong with me? He said, I don't know, but your eyesight is perfect.
Love it.
Some vomiting throughout the decades. So this is vomiting in politics. This is a picture of George Bush vomiting in front of the Japanese prime minister back a long time ago. The general understanding is that he had simply had a bout of gastroenteritis for that one. This is, oh shoot. Yes, Messi, thank you. Soccer player, and speaks to the exertion we sometimes see in athletic events, sporting events, where sometimes you put forth such effort that you are left vomiting. Again, not gastroenteritis, not chemotherapy, exertion that does it. Let's see here. I lost trigger again here, John.
That's because I'm messing around with the screen.
Right. Vomiting in pulp culture. Who's this person?
Yeah, Lady Gaga.
Wow, we've got some good people here. So this is Lady Gaga and her cohort on stage in a famous. Now this was actually self-induced. The picture prior to this will show her putting her finger down her throat in order to to do this one. So not quite sure what the creative energy is that's going on here, but there you go. And then group vomiting. This is a scene from a movie. Anybody recognize this scene at all? Okay, this is a movie called Stand By Me. And this is a prelude to group vomiting. So this is a pie eating contest, and this guy overstuffs himself. He ends up vomiting. And then as this progresses, the various people who are in attendance of this big event, they all will start vomiting. It's just kind of this very interesting psychological phenomenon of other people vomiting makes you vomit. So there's probably some evolutionary component to that, but that's kind of a big scene there. And then, of course, vomiting in October. You have to have a pumpkin there. So historical remedies for vomiting, included bloodletting. We don't do that anymore. Ginger, we do that sometimes now. Mint. It's been a long time since I've ever used or even heard of anybody using frankincense. But no myrrh. But these are old things. And then here's one of my favorite jokes from our good Dr. Alice Emery. What's the best food to eat when you're vomiting? Bananas, because they taste the best when they're coming back up. Dr. Emery did a lecture here just a few weeks ago on, I think, physician wellness. Yeah. As part of our context for talking about this complicated symptom challenge, I'm going to include a case study. And this is an 84-year-old woman diagnosed with ovarian cancer who underwent surgery and then chemotherapy and developed, unfortunately, diffuse abdominal metastatic disease, which then contributed to a partial bowel obstruction. So she had lots of things going on. She had challenges with nausea, vomiting, challenges with swallowing, and challenges with gastroesophageal reflux. This was a historical challenge. She'd had lots of heartburn. This woman had some challenges distinguishing for us between what was nausea and what was heartburn. She also wanted to keep eating. This was something that she felt was important to her, even though she was 84 years old, had stage 4 cancer, and was declining. She wasn't ready to say, I don't want to not eat at this point. So that was a goal that's, I think, important to keep in mind anytime we're talking about our patients. But what are their goals of care? And one of her goals clearly was, I want to keep eating. So the etiology of nausea, we're going to come back to a somewhat similar chart here in a few slides. But this kind of starts to speak to that orchestral arrangement that we were talking about earlier. So the chemoreceptor trigger zone, that's the CTZ is what it's called. It's a specific placement of the brain. And I'm going to lose my, having difficulty seeing that.
Yeah, I'm looking at it. We move this for you. There you go.
So anyway, up on that diagram, you can see there where the vomiting center of in the medulla is kind of ultimately what we're hitting. And we come to that through various pathways. Number 2, the vestibular apparatus. So you can see that there on the left part of that diagram. This refers to that part of our inner ear where we have the labyrinthine canals and the triggers that will come to that through the brain to then get to that vomiting center. The cortex, the cerebral cortex, so that's at the top of the diagram there. Different injuries that can happen to the cerebral cortex. We'll talk about that here in a little while. And then, of course, the GI and peripheral pathways there at the bottom of the diagram that will also influence that part of the brain there. So at the bottom of that diagram, if you can see it, these different areas of the brain that will produce that sensation of nausea and then vomiting are also, they have different chemoreceptors that are part of that. So we'll explore that here again in just a little bit. So when you're assessing a patient with nausea and vomiting, you want to pay attention to a number of different things. In the same way that we document pain, we're going to want to document nausea and vomiting. So when did it start? How often are you vomiting? What is the relationship to eating? Any new medications that you're taking? What current antiemetics are you taking? And by the way, then, of course, just like when we have pain patients, if we've got PRN medications, the important next question to ask them is how often are they actually using their PRN medications? It still happens to me very often when I get calls from a nurse with a pain patient, and they'll say, well, Dr. Wyn, they've got Roxanol ordered, 10 milligrams Q4. And so I think we need to go up on that. But my follow-up question is, well, how often are they actually taking the Roxanol 10 milligrams Q4? Same thing that we run into with our patients here. We want to know what their actual use of those PRN medications is. We want to know, is this a chronic, progressing symptom? What are some of the alleviating factors? What is the severity? And again, we want to finish up with what is the goal of their care here? What is the goal when we're talking about pain? What's the goal? Pain management, what's the goal here? We want to identify potential reversible causes. That's the easiest way to start to manage this problem. So different drugs that can be coming on. If they say, hey, Dr. Wyn, I just started a new chemotherapy, well, that helps. If they started a new antibiotic or a new NSAID, a new opioid, of course. Constipation. Constipation certainly can contribute to nausea. Relieve a blocked stool, and you can get a lot of relief of their nausea and vomiting. Gastroparesis, run into this periodically, especially in the setting of poorly controlled diabetes. GERD, we've talked about, uremia, various infections. And then other things, pain. Pain and nausea can run together. Dehydration, electrolyte imbalances, particularly a hypercalcemia, can contribute to that sensation of nausea. Endocrine dysfunction, increased intracranial pressure. We'll talk about that one again a little bit, but that's a cortical stimulation. So is anxiety. So lots of different potential causes. And then some other things as well. So things like pregnancy, cyclic vomiting syndrome. I think you probably are all familiar with this, but I can still remember when I started hearing about cyclic vomiting syndrome in relationship to prolonged marijuana use or robust marijuana use. Certainly liver disease and migraine headaches, post-surgical nausea, vomiting, MIs, myocardial infarctions present oftentimes with nausea. Sometimes people who are violently coughing will have a post-tussive vomiting. Good old hangovers and Meniere's disease. So lots and lots of things that can be going on in the setting of nausea and vomiting. This is coming back. That's a different version of that same sort of diagram we saw a few slides ago. And so I'm just going to kind of review again here. So you see in the middle of the screen there that chemoreceptor trigger zone part of the brain, which then is a direct stimulation of the vomiting center located in the medulla, which then produces nausea, vomiting. Some things will have a direct impact on that vomiting center to the medulla. So at the top of the screen here, some of that sensory input, anxiety, meningeal irritation, increased intracranial pressure, those things directly, that cortical stimulate goes directly to the vomiting center in the medulla. Other things will first pass through that chemoreceptor trigger zone. So like I mentioned the vestibular symptoms, so motion sickness or labyrinthine disorders there. Those down in the bottom part of your screen there where the peripheral receptors and the GI tract receptors exist. And then kind of we're here in the middle of the screen there again, drugs, metabolic products, those different challenges there. They are mediated by some different chemoreceptors, and we're going to talk about those in a minute. The memorization of this slide is not important. The main reason I'm putting this there is just for all of us to understand that this is a complicated process, that there are different ways in which this process gets activated, and therefore there can be some, there's ways in which this helps to inform the different ways that we will go about treating this.
Does that also help to explain why sometimes, and I know you're getting into the treatment side, but you know, I think that in medicine we try to be as specific as possible when we can,
right?
In terms of hitting specific receptors with specific drugs. But
right.
I've always kind of viewed nausea and vomiting as one where there's so many different centers that are involved.
There are.
With so many different receptors.
There are.
That we tend to use more of a shotgun approach sometimes.
Well, and this brings us to this slide, which was most patients have multifactorial causes.
Oh.
And this is the orchestral involvement of the gut.
There you go.
So sometimes we're going to be faced with patient, and I kind of love this orchestra analogy. You're going to hear sometimes different solos in the orchestra, and sometimes with your nausea vomiting patients, there's going to be different solos, and it's going to be a little bit more clear, kind of more precisely what's going on. However, most of the time it's messy. There's not usually just one thing that's going on. Most patients do have these multifactorial causes. We're dealing with an orchestra. It's important to come back to remember non-pharmacologic treatment. So reassurance is actually a big one. I think this is important for a lot of our patients, reassurance and relaxation, the setting of pain, the setting of nausea. Correct the things you can correct, dehydration, electrolyte disturbances. This next one is I think a big one, decompress. If you've got a bowel obstruction, all the medications in the world will be, I think, ineffective. Decompression is sometimes the most important thing you can do for them. And sometimes that also means things like correcting the constipation. Oral hygiene. So many times our patients, especially those who are in hospice, they've gotten weaker. They get their face cleaned, they get their hair done, and they get their teeth brushed and their mouth cleaned up. And they feel so much better. I think for all of us, you're on a long trip and you're on a long plane ride and you get home and you take that nice shower and you clean up. Cleanliness, and especially head and neck and oral cleanliness, goes a long ways towards making ourselves feel better. When it comes to eating, reduce portions. Cold food seems to be better tolerated than hot food. Reduce or eliminate tube feedings. We're going to come to that one here in a little bit. And avoid odors. You don't want to be doing this as your job. I keep feeling like that must be in Russia someplace where they're going through and testing different deodorants, but yeah. And when you can, so this is back to John's point earlier, when we can, we're going to try to match the etiology with the mechanism. So for instance, the chemoreceptor trigger zone, we're looking at dopamine and 5-HT3 antagonists. For the vestibular system, medications that might be included would be antihistamines and antimuscarinics. Cortical stimulation, again, antihistamines, anxiolytics can be beneficial there. And in those GI peripheral pathways, we're again running into those dopamine antagonists and those 5-HT3 antagonists. Match the medication to the mechanism. So when I talk about D2 antagonists, what am I talking about? Well, lots of them out there, but some of the big ones that we use are Haldol and droperidol. Droperidol is often used in the emergency department, I find. Reglan, it used to be one of your favorite medications, John, maybe it still is.
Still like it.
Yep. Compazine, and then an old one, Thorazine, is out there. It's rare these days that I use Thorazine in the setting of nausea. In my experience, when I use Thorazine these days, it's almost exclusively been for hiccups, but there you go. It is still a dopamine antagonist. The 5-HT3 antagonists, these are things like Zofran, probably the single most commonly used antiemetic out there. Remeron is also a 5-HT3 antagonist. And the others I don't tend to use very much. Kytrol and Emend. Maybe others use Emend a little bit more. I'd be curious to hear from the group about that. Antihistamines, Benadryl and Phenergan and Antivert and Cyclizine, they have their place in this. I think their place may be more that they sedate you and just kind of get you through it. But they do seem to have some benefit in the setting of nausea. Anticholinergics like Levsin and scopolamine have their place as well. Promotility drugs, particularly Reglan, Propulsit's not used as very often anymore, but Reglan is a promotility agent. It can be an appropriate one. Choosing that one, I think, somewhat carefully. You don't want to use that in the setting of a complete bowel obstruction, of course, but otherwise can be a very effective one. And so that one's getting 2 for the price of 1 because you remember that's also a D2 antagonist back up at the top of the screen there. And then some others that we will throw out there that can be very important. Decadron, steroids, very good antiemetic. Ativan, and then Zyprexa. I've seen over the last several years, Zyprexa has really started to take on a role of prominence in the treatment of nausea and vomiting. Questions about that slide at all so far? Okay. We'll just kind of tackle a few of the different types of nausea, vomiting. So opioid-induced nausea primarily hits that chemoreceptor trigger zone. Treatment for this, you can consider opioid rotation. Some people, morphine is really well tolerated, but for some people it causes more nausea and vomiting. Others may have more challenges with some of the others like Dilaudid. So finding where people are at, and sometimes that's just a matter of trial and error. With all the different genetic testing that's going on out there. Particularly, I think that's helping to inform choices of antidepressants. At some point, it seems likely that we'll start to get some understanding of which sort of narcotics work best for patients based on genetic testing. For opioid-induced, if you can't fix it by changing their opioid, think a D2 antagonist. So Reglan, Haldol, Compazine, Droperidol. Chemotherapy-induced nausea and vomiting. This seems to mainly be from 5-HT3 pathways in the gut and the periphery. So then think things like Zofran and Kytril and Amend and Remeron. So whenever I have this slide up there, I remember back to, again, a long time ago, Zofran had come on out. It seemed to be wonderful in the setting of chemotherapy-induced nausea. And that's how we were educated it was supposed to be used. It was specifically for chemotherapy-induced nausea and vomiting. And I can remember being in the emergency department one day, and one of my partners, Kathy Campen, had used it on one of her kids, a pediatric patient there. And it worked great. It's an oral dissolving tablet. And that child clearly had gastroenteritis, did not have chemotherapy-induced nausea, vomiting. And I remember prior to that point, we'd kind of all been told it's really not effective in the setting of gastroenteritis, but turns out it really still is. So even though we still think of it as a chemotherapy based medication, or at least I still do, Zofran has clearly efficacy in other settings as well. Malignant bowel obstruction. So this is when you have a whole bunch of tumor in the gut. You've got maybe a lot of peritoneal metastatic issues going on, maybe bowel obstructions happening. And then you're going to get a stimulation directly of that chemoreceptor trigger zone. So here again, think D2 antagonists, octreotide, which is given as an injection to help reduce some of the secretions, can actually be a very effective strategy there. Steroids, I find steroids here really can be kind of critical. They help to reduce some of the inflammation, maybe help reduce some of the swelling that's happening within the gut. And then decompression. So putting an NG tube down this patient, or doing a venting gastrostomy tube. So this is a situation you run into not commonly, but not super rare either. You're going to run into this situation with patients. And if they're coming onto hospice, sometimes one of the most important things I do before they leave the hospital is say, let's put a venting gastrostomy tube in them so that they can be much more comfortable. That's, I think, just a key one there. Motion induced, this is, we all have experienced, well, maybe not all, but many of us have experienced motion sickness, primarily from stimulation of the vestibular system. Think antimuscarinics here, so the scopolamine patch or the Levsin. Antihistamines like Anavert and Phenergan. Increased intracranial pressure, we'll see that with patients periodically due to a variety of different things. That directly stimulates the vomiting center. And you treat that with steroids and oftentimes, sometimes antihistamines, but relieving the pressure. So sometimes actually you'll see patients get intracranial bolts put in to help relieve the pressure. Shunting can be of benefit in those types of situations as well. And again, most patients have multifactorial causes. When we talk about dosing, go hard or go home. By the time patients get to us with this problem, they've usually been on more modest doses, more PRN dosings. Sometimes various medications have been changed and some have been discarded because, quote, they weren't working or so anyway, by the time they get to us, you're kind of past that small dosing types of stuff. So just be open to more aggressive, more robust dosing. So using appropriate doses scheduled around the clock. Sometimes very important to do this. Instead of just having it be PRN, get it going scheduled around the clock and do it that way. So coming back to our case study, that was the 84-year-old lady with the ovarian cancer who wanted to keep eating. So one of the things we did was we put her on Reglan at 10 milligrams scheduled twice a day. We used Zofran at 4 milligrams 4 times a day. And we put her on a proton pump inhibitor, mainly because of her ongoing concerns about gastroesophageal reflux disease. And that seemed to help her for a little while, but then things got worse again. And she was more nauseated, not really vomiting so much, but nauseated, this heartburn kind of a thing that was going on there. So we ended up adding then Phenergan and an H2 blocker. I can't remember which one that was, but we had minimal improvement then. So we had her on Reglan and Zofran, we had her on a PPI, we had her on Phenergan, we had her on an H2 blocker, but not really not getting the results that we wanted.
Then she stopped eating.
Now you're going to steal my thunder here. So, Matt, I've got Matt, for those of you who couldn't hear, one of our fellows just said, and then she stopped eating. So that can be a key thing. And I do want to come back to that here in a little bit. So, but first we want to talk about intractable nausea, vomiting. So you've done your regular doses, you've done them scheduled around the clock, and still the patient is vomiting. What are your kind of biggest guns you're going to be able to bring out at this time? And then we're starting to talk about polydrug regimens and routes of delivery. So general guidelines, try not to use more than one medication from each class. And the same when we talk about pain management, I don't usually use 2 different long-acting opiates or 2 different short-acting opiates in the same way here. You know, try not to use more than one drug from each class. There is some crossover sometimes. Think about some of the less traditional medications, coming back to the steroids, the Ativan, the Zyprexa, and start to consider alternate routes. If you've got a patient who's having continuous nausea and vomiting, the oral route sometimes gets to be particularly challenging. So topical can be talked about. That's not really particularly practical. Rectal, you can give some of these medications as rectally, and they don't need to be specific suppositories. You can sometimes use tablets that way. And we're going to spend a little time talking about the subcutaneous route. So be alert for drug interactions, of course, because we start talking about polydrug regimens. That can be a challenge, but we oftentimes need to look at that. Continuous infusions. So these have the potential to provide quite quick and effective relief of that intractable nausea. And they can then, after they've been given as a continuous infusion, sometimes they can be transitioned over to an oral regimen. And what we're talking about are 2 different ones that, I mean, John, you came up with these recipes a long time ago. Benadryl, Ativan, and Decadron, the bad drip. Which consists of, as we talk about Benadryl, Ativan, and Decadron. I've included the recipe there a little bit for you. And then the other one is the RVD drip, and that's Reglan, then Benadryl and Decadron. And John, I'm going to invite you to just kind of speak to these infusions here for just a minute, since
Yeah,
you have the stories there.
Why they work still remains a mystery. They do. And that's experiential, going over about 25 years worth of history with these types of things. When all else has failed, these seem to have provided some great benefit. If you just quickly do the math in your head, you'll see it's a very, very low dose of drug. And we've got there's good evidence that there is safety of these combinations. There's something that work in the literature about the safety, but they've never been trialed. And so we don't have the science that can confirm what we see experientially time and time again. If you use, for those on the call who are local, you don't necessarily need to remember the recipes, because if you're using a local infusion service, they all have the recipe and they know these. What was interesting, it was kind of cute when we first introduced this over at Spectrum, now Corwell, 15 years ago or so. They refused to send anything up from the pharmacy that had bad on it. So they changed it to ABD. So it was the ABD drip instead of the bad drip. And then working with Polly over at who was the oncologic pharmacist over there at Spectrum, we kind of put the Reglan in there also. And so we had the ABD drip and the RBD drip, and then sometimes we would actually have all 4 and call it a batter drip.
Oh,
So, and I think that the opportunity, because I like the image of the orchestra, and because so many times nausea and vomiting is multifactorial in nature. What this does, if you think, just kind of think what Tod was just sharing in terms of the different pathways that are accessed, the different receptors that are involved, and the different structures that are involved. This is a broad-based approach to hit as many of those that we can as safely as we can.
Mhm.
And so I just experientially, this has been effective. And I wish we had better science to validate it, but
So Bob Johnson, you remember Bob?
absolutely.
Bob Johnson was a internist hospitalist and did his palliative medicine fellowship out of Ohio State.
Yep.
And Bob used to give a presentation here, in a very research oriented physician. And he had done some different work specifically with the steroid aspect of this. And so I know Bob was pretty convinced that it was really more the steroid that was involved here. But it does seem to be some power in the combination. I actually wanted to include the recipe for you in some ways, because when I first came out of fellowship and then went into our local community over at Holland and went to that hospital, and I wanted to do this infusion, they needed to know the recipe. So I came up with the recipe, gave that to them, was sitting down with the pharmacy manager, the pharmacist, and going through things. And they, of course, wanted to see some backing on this. So they had done a Google search, and they'd like, oh, we came up with this presentation here. I'm like, that's my presentation. You pulled up there. They had found online somehow. And anyway, so I thought, you're not really casting a wide enough net there to do that. But it's a formula just for you to kind of put into your own documentation.
I was presenting to the P&T committee over at again, formerly Spectrum, to get this added to their to the formulary. So P&T committee, and the same thing. They were looking for some specific science, and at the end, I just said, I said I can give you 2 or 3 articles that validate its safety, which is our number one primary concern, right? And I said, but here's what I do know is that when you're lying in the bed up there, puking your guts out, and nothing on the formulary is working, you're going to want to make sure this is available to you.
You've seen it. I've seen it many times where this has been just a dramatic help for people. And it's nice to have this in your back pocket. Other formulations we could consider at some point, but probably never will. Alternative therapies, we'll spend a little time talking about that. Acupuncture, acupressure, Korean hand therapy, aromatherapy. Whatever your views on these different things are, there's some reality to the fact that they can be of some benefit to patients. And just to kind of climb onto John's more recent comment, they're safe. So acupuncture, I know very little about acupuncture. This slide probably sums up everything I might know about acupuncture. But there are 5 phases to the theory, and generally believed to be more helpful in the setting of chemotherapy and post-op nausea. But I'm unaware of any particular good research that's done on this. It would be interesting at some point to actually have somebody with some knowledge of acupuncture really speak in the setting. I'd be curious to hear what they have to say. Acupressure, this is an easier one for us as practitioners to do. So specifically here, what this is a zone they refer to as the Niguan point, the P6 point, and pressure on this area. So this is the ulnar aspect, of the forearm, right at the wrist there, kind of in the center, maybe a little bit more towards the thumb. Putting pressure on that area seems to result in some benefit. So when we talk about over-the-counter C-bands, these are compression bands that fit. They are designed to put some extra pressure in that area.
More specifically, if you just take your hand and you flex it just slightly, you'll palpate 2 significant flexor tendons on the wrist there. So you go 3 fingers from the distal wrist crease there. So the distal flexor crease, 3 finger breadths down in the middle of those 2 flexor tendons. That's the P6 point.
Yeah. And
so what I have found where it hasn't worked is that they put it right in the middle, which is just off to the side. It's just to the ulnar
What are
side.
you guys doing? Stop that. Come here.
what are we doing?
No, she's. No.
Oh.
Good. Yeah. Had to be muted. But that's the proper placement of that. And you can do this, by the way, at the bedside. When you're sitting
Yeah.
at the bedside, and normally where you would go to check a pulse, you slide down just a little bit, move your hands over and put a little pressure on that spot while you're talking to the patient. And they're going to think it's your wonderful bedside manner that has relieved their nausea. And that's partly true also.
It is true also.
That is the cerebral cortical effect
Yep.
of your compassion and bedside manner. But you can have some value there as well. So
yeah. Korean hand therapy, just to kind of put that on out there, the understanding that kind of like we run into with what's the foot medicine or the foot manipulation theories that you can stimulate different areas of the body by massaging parts of the foot. Same thing applies to Korean hand therapy there. The idea that you can have some
reflexology.
Reflexology. Thank you. Yeah. Aromatherapy, there's probably some value to this. So coming back to the earlier part of my slides there, ginger and peppermint and lavender and lemon oil, these types of things. You have a little of that in a room, not a ton of it, but a little of that in a room can have a very nice effect. How many of us like to come into a room and it's smelling of baked cookies or of popcorn, and immediately kind of gives a sense of comfort and happiness and this kind of a thing. Similarly with aromatherapy in this setting, it can only, I think, benefit you. Well, you can go overboard, I suppose, where it would be really could have a counter effect. But every once in a while, I've recommended to patients they get a little diffuser and they get some oils and they put a little mint in the air. We should talk a little bit about marijuana. THC, tetrahydrocannabinol, demonstrated effectiveness in amelioration of nausea and vomiting and helping with inducement of some hunger in patients, particularly in the setting of chemotherapy or AIDS. It may have some analgesic properties, certainly seems to have some benefit in lowering intraocular pressure. Lots of research being attempted at that. Not a lot of clarity yet coming from that. But it is something that I think we can be open to in our patients, especially given now that there is our dispensaries available, and we can talk a little bit about that here in just a second. Mechanism of action is unclear, but probably involves inhibition directly of that vomiting center. And there is an extensive first pass hepatic metabolism. So administration and dosing, the usual advice that I will give patients if they want to explore marijuana is that I do not typically recommend smoking it. It's hard as a physician to recommend smoking a medication. It's still got, CO, it's still got tar. You're going to get kind of a quick peak effect and then a quick decline. It's just probably not a very effective thing to do. Vaping, maybe a bit more predictable, but jury's still kind of out on exactly what the implications are of vaping marijuana. Ingesting it, so this is probably the most common way I have patients take THC. They'll take it, it peaks some hours later, usually at a much lower level, then gradually declines. You can still get that psychoactive metabolite, so you're not protected from that, where we. And they have not yet made a marijuana suppository, as far as I'm aware. That's a joke. So there are synthetic forms of THC. So the most common one that we use is Marinol. That's a Schedule III drug. There's also another one called Casamet. It's available in Canada. I have used Marinol in the inpatient setting. It's sometimes it's helpful, sometimes it's not as helpful. I guess my general viewing of these synthetic compounds is that they're quite safe and they're accessible in an inpatient setting. They tend to be expensive. Insurance companies, as an outpatient, don't particularly like paying for them. And they're probably not as effective as the actual plant. So I don't often use Marinol in the outpatient setting. If I have patients who really want to explore this type of treatment, I'm actually at this point usually recommending they just go to a dispensary and give it a try. But I'm usually recommending that they do it eating, ingesting it. And then I'm also usually recommending that they go through a dispensary in large part so that they can have some predictability to what they're getting. If they're getting it from a friend or if they're getting it in some other avenue, At any given time, they may be getting a different plant. They may be getting a different recipe. There's going to be a real lack of consistency unless they're going to go through a more formal setting. So good research remains difficult, but it's getting better. Specific plant dosing and administration probably does matter. It does still have side effects. I think for us to be glib is inappropriate. Marijuana has side effects and drug interactions, and it has actually recently, there's this I did come up recently. There's been a potential link to head and neck cancers for people who are using large amounts of marijuana. Not been firmly established as a cause, just there does seem to be, in some of the research now, there seems to be some link there. Those most likely to benefit are those who have not responded to other more traditional interventions. Those least likely to benefit are the elderly who've had no prior experience. Those, however, are the patients that we bump into most of the time, are the elderly patients who've had no prior experience with marijuana, and they've usually got a family member who's kind of gung-ho on marijuana and wanting to do this. And again, they usually have my blessing with that, but it always comes with a caution. Be aware, you may get high on this. You may or may not like that feeling of getting high. Be cautious in your dosing, and don't get it from your grandson's friend. Get it from someplace that has some consistency with it. And then I'll close on the marijuana with this idea that positive thoughts matter. This is not just true for marijuana. It's true for so many different things. But for those patients who come to me and say, boy, I'd really like to try it. My son has had such good results with it, or I had a friend who had such good results with it. What do you think, Dr. Wyn? Well, they've already kind of told me that they may benefit from it just by their positive energy with it. I find that true in the setting of pain management. How many times have we had patients where they're on a pretty robust dose of oxy and they'll say, oh, I really just wish I could have my Norco back. That's what really used to help me. And I'll look at the patient and I'll say, well, I don't say this, but I know that their Norco is going to be less potent. There may be, in terms of morphine milligram equivalencies, they're going to be on less narcotic. But when I make that switch from the oxy to the Norco and I do what they've kind of wanted to do, so many times those patients feel better on less medication. Same thing seems to be true in marijuana. If they've got some good positive energy going for this, and then I give them my blessing and say, go ahead and give it a try, I think that those patients generally tend to have a more positive response. So our case study conclusion: patient was placed on a subcutaneous bad drip, which was gradually increased and continued with the other H2 blocker and the PPI. We gave her GI cocktail, which is I don't know if you guys even know what that is, but that's a combination of Malox and viscous lidocaine. It seems like we used to put another thing in there. Benadryl. Yeah. She responded well. But I'm going to come back to the comment that Matt made. So what I don't quite have on this slide was that she stopped eating. And so even though in this case, this patient did well, what really did seem to also help her and kind of coincided with her doing well was she decided, I'm just going to stop eating. And that can be a very important thing. And we also see that in our patients who are on tube feedings. Patients who have said, the tube feedings are sustaining me. I really need to continue my tube feedings. But we find that once we actually talk the patient into either reducing or stopping the tube feedings, that seems to be a very important factor in them actually getting some relief. So she ended up passing away comfortably. And I think overall, when those last few days or couple of weeks can be comfortable, that's really seems to be very critical in the patient and the family's perception of how she was. Random thoughts. So Decadron is a great antiemetic. Haldol and Zyprexa are as well. So make sure just to kind of keep those in your back pocket. Decompression may be necessary. Combination drugs, different mechanisms may be helpful, and anticipatory dosing is beneficial. Successful strategies: attempt to identify the most likely etiology and mechanism involved. Choose the medication based on that mechanism. Dose appropriately and on a scheduled basis. If ineffective, consider multi-drug regimens. Consider continuous infusions. And consider less traditional interventions and medications. So that concludes. We've had kind of a quiet gallery so far here, both here and online. or on digitally. Anybody with any particular comments, insights, reactions, their own thoughts on how to approach this?
I just Fred had just affirmed that he likes olanzapine.
Yeah.
Low dose generally has advantage of the side effects and the side effect of potentially stimulating appetite.
Yes.
And I think that you'd mentioned that's becoming more in vogue. And there's actually, I think, when we think about antiemetics, because there's you reference the kind of the thought process and the cortical, the cerebral cortical impact on that. It makes it, I think, very difficult. If you look at the studies on antiemetics, so many people respond to placebo.
Mhm.
So many people have side effects from placebo. It's really tough to sometimes sort the science out on that.
Right.
And one of the more poignant back in my Spectrum days, there was one of the nurses that was on the floor had in the early days been a chemo nurse, like back in the 70s, back before we had a lot of these antiemetics, and so nausea and vomiting was just an expected natural part of the chemotherapy experience. And she told a story of going to Meyer and getting out of her car, and she saw down about 4 cars down, one of her patients was getting out of his car. He got out of the car, he closed the door, looked up, saw her, and immediately vomited onto the pavement. So that those emotional and those psychological triggers, and we can use those both on the positive and the negative side. I mean, we can again the kind of the reassurance, the kind of the positive thoughts there.
Right.
Anyway, so what I was getting was that there actually is some better science on Zyprexa than on most other things. And here's just a little known, totally irrelevant factoid, is that when the FDA started their process of approving drugs and needing science to approve them, they grandfathered in not many, but a few drugs that didn't have science behind them. One of what they did was Phenergan for nausea and vomiting. There was no science, but they approved it for nausea and vomiting. And if you've ever tried to use Phenergan for nausea and vomiting, that didn't really show up much on any of your slides. It's because there really is no understood value in nausea and vomiting, other than it sedates people and causes them to sleep a little bit, so they become unaware of their nausea.
Yeah.
So other questions here, Tod, from Michael. How do you infuse the bad drip? 1 day, more, indefinitely?
From how do I infuse the bad drip 1 day more or
yeah.
Well, so in the hospice setting, if I'm doing a bad infusion on an outpatient, and this is not that uncommon. By the way, these infusions are much easier to do at home than they are in a facility. Depending on the facility, sometimes you can do them, but for the most part, I can actually get more aggressive with patients medically in the home setting than I can in some facilities. But I'll do it as a subcutaneous continuous infusion at home, much in the same way that I might do a subcutaneous infusion of morphine. And usually at the point on a hospice patient, yes, I'm looking at it as being kind of a what's the word? Not bridge, destination, sort of a destination therapy, where I'm expecting that they're going to probably be on that until they pass. Okay. When I'm using it on an inpatient side, it would be more as bridge therapy, where I'm looking at it to try to get control of that patient's symptoms and this would be under palliative care. And then once we have the control of their symptoms, then looking to come up with a transition of getting them onto an oral regimen. In my experience, that's not usually done in a day. I usually would have to titrate the bad drip over the matter of a day or two, oftentimes to really start to get managing of their symptoms. And then transitioning to an oral regimen probably takes another day or so to start to look at, depending on how close your follow-up can be on an outpatient basis. But that's probably typical for me. You say that was Michael who put that question?
Yeah, and
there?
he's got another follow-up question also here. And this is new to me. And if you got, Michael, if you want to speak to it, I'd love to hear it. He asks, has anyone used inhaled isopropyl alcohol?
No.
Or like just smelling?
Well, it's inhaled, I presume,
Michael, if you're on, you want to speak to that, I'd love to hear what you're talking about.
Yeah, at the AAHPM meeting, there was a talk about that, or it was mentioned in one of the updates that inhaling isopropyl alcohol apparently is evidence-based for reducing anticipatory nausea related to chemo. And I was just wondering if anybody's had any experience with it in refractory nausea and vomiting.
I love the idea.
I've just heard of people using like.
How was it accomplished, Michael? What was the?
Alcohol pads, open it and sniff it.
Oh,
Oh, no. Well, okay. That seems pretty simple.
I've heard of people using that for flights, like on flights.
I wonder if you'd like to talk.
Steve does it at home?
No, in the hospital. We do use it, and it seems to be effective.
It's Steve's on the call. I see you up there. If you want to give us some real life examples, that would be great. The other thing, and Gretchen mentions that Up to Date has great tables on chemo-induced nausea, including the emetogenicity of the agents and what antiemetics to use based on the emetogenicity of chemo. And I think that's great, and I love that. I mean, in the attempt to be as targeted as possible.
Right.
And I think sometimes we sort of forget that Up to Date's out there.
Right.
It's a great resource. I found that because they are so stringent with their evidence basis, they may not be as creative as some of us need, and a lot of our patients don't fit into the Up to Date categories of inclusions and exclusions, and so we need to kind of go outside there a little bit.
John?
Yeah, go ahead, Steve.
Yeah, the fellows taught me to use the isopropyl alcohol wipes. One of the fellows working the weekends gave a patient a box of them, had them inhale them every 15 minutes PRN. So we routinely do that at UMH West. Also, we do you remember lidocaine nebs, John?
I've done lidocaine nebs. I've never done for nausea.
I've been using it for nausea, and
no
it works great. But 95%, the Cleveland Clinic says that 95% of all nausea is relieved with Reglan and low dose Haldol, or we use Zyprexa now. And I have to say that's pretty accurate.
Yeah.
Yeah. Well, they have broad base, and yeah.
Okay.
So there you go. There you go, Michael.
Yeah, thank you for that.
Validation on the effectiveness of, and I would think it's relatively inexpensive too.
Mm-hmm. But I was going to mention something you had mentioned, about odors.
Yes.
So in our IPU, I was mentioning, I was talking to you about it, kind of like Trillium. I remember we had a patient, family went into the room. We have a large family room to eat, but they brought in it was greasy food, hamburgers, French fries.
Right.
This patient was completely attunded and started going into kind of what appeared to be dry heaps.
Oh.
And I asked the family if they could remove the bags and whatever, and it just kind of went away. So now when the families come, I see food, as long as there's food that they're eating that you can't necessarily smell, like a cookie or a Coke, I have no qualms, but I just ask them if they're going to bring in pizza, hamburgers, that kind of stuff, you might want to go to the family rooms.
Yeah. Yeah.
A few decades ago, the Mayo Clinic decided they wanted to create a more home-like atmosphere on their wards because they're sterile. It's a hospital, right? But they had, so they thought just putting a loaf of bread in the oven or some cookies in the oven would give this nice, wonderful home smell. So many people got nauseated as a result that they had to quit doing it. So there's a fine line between those aromas that really kind of bring some sort of peace and hominess, and those that actually have therapeutic value in terms of the aromatherapy.
Yeah, very interesting.
And Gretchen asks, relative to the ABD and RBD drips, to use bolus during that in addition to the continuous rate. I think it's a great question. And historically, that's what we started doing when we started doing this, Gretchen, was using boluses. And the bolus was exactly the same as the continuous rate. So if it was a 0.2 an hour, we did 0.2 as a bolus. I really came to really appreciate over the years that was, again, more psychological benefit to the patient. They feel like they're doing something active to try to relieve their nausea in that moment than it was pharmacologic. Again, no harm, no foul. So I don't think it's a bad thing to do. I just don't know if there's much actual therapeutic benefit to bolusing at that particular point in time, simply because the doses are so low.
With the ABD and the RBD, is there any kind of reasoning between the differences in the common elements, which is like the Benadryl and the Decadron, the dosing being different between those two infusions when you made them? I noticed one is listed as being like 220 Benadryl Decadron, the one that's like 100 and 8.
Well, actually, because the rates are different also. And so the rates accommodate that,
Okay.
the math. And it really was done because of the concentrations of the Ativan and the Reglan.
This is Ken Hansen. I had a quick question on the ABD drip. Does anybody run into problems with the getting pushback from the hospital that it's an Ativan infusion, and so you have to put them in the ICU? I had that at a previous institution. It's kind of frustrating because it was like when you look at the amount that they're getting IV, it's so small.
It's a good question, Ken. I'm going to let John has a story about that. I'm going to let him tell you that story. I will say that yes, we do run into this. So I'm just going to talk about Holland Hospital. So when we put this into place there, they wanted to put patients in the unit for that. And although I too find it frustrating, I'm also sensitive to the fact that these are medications that the pharmacist can get a little bit understandably nervous about. The hospital gets a little bit nervous about. I don't want my pharmacist, I don't want the hospital being nervous. So if for them that part of their protocol needs to be putting them in the unit, that's okay. I think in that hospital, even the unit beds are usually pretty comfy. I think this. Not quite sure what that was, but anyway, just so I've attempted to provide reassurance for our pharmacists and hospital staff, and I find that as they get a little bit more used to it, there's a little bit more flexibility on it. But when initiating it, definitely ran into having them wanting to put patients in a more monitored environment. And then I'm going to let John tell his story about Ativan.
Well, this is the first time that we had employed the drip over at Spectrum, and went through a lot of hoops to be able to do it. And they finally said, "Okay, we can do it." And so this is a patient that had was post-op. Had who's got their okay. So this is a post-op patient from having surgery for metastatic pancreatic cancer, and there's some questions as to why they had surgery with metastatic disease. But anyway, that's by the by. They had the surgery and was having a lot of nausea and vomiting and pain subsequent. So I was consulted, and they had tried all the usual suspects, the Zofran, the Compazine, and things like that that would normally be done post-operative for post-op nausea. So I started the ABD drip, and I started a morphine drip. And during the day, when I went home, the patient was comfortable, was resting, the nausea was relieved, and the pain was relieved. The patient then had a spontaneous bleed and died overnight. Code was called, and the responding team was a little irate that there was an Ativan drip hanging. Well, it wasn't the Ativan drip; it was the ABD, but with had Ativan in it. And so that resulted in an inquiry and just a lot of questions in the weeks they had. They ultimately ended up investigating to make sure that somehow that didn't contribute to the patient's death, an Ativan drip. And it, again, but say, well, the patient exsanguinated, and was comfortable. And here's what the rate was. The pharmacy verified what the concentration was, but then they decided to analyze the contents of the bag and discovered that the type of plastic that they were using in the bag was absorbing the Ativan. So there was no Ativan in the drip whatsoever. So relative to your comment about Bob Johnson's thought that the Decadron, so this patient was only getting Benadryl and Decadron in terms of the drip. And that produced effective antiemetic drip. Now, to that point, after all of that, they still allowed, and I would guess that they still do allow the drip on the floor. But that was one of the questions then that came up: is there an alternative to the Ativan that we could consider in doing a multi-drug infusion? And that's where Polly and I did the Reglan. Switched out the Reglan for that and used the RBD, mostly, not exclusively, but since that time. So, and we realized that if we're going to use Ativan, you can't use the same bags that they use for everything else,
right?
Because of whatever it was about that bag. So, anyway.
And John, I was just going to ask you: have you noticed a difference when you switched that Ativan? between the two? Is one better than the other?
They're both effective.
Okay,
And I think that's a great question in terms of what's the rationale for picking one or the other.
yeah,
I don't have one, except that I just had a sense that so much of nausea is wrapped up in anxiety. It's a vicious cycle. And so I really have found that historically, even forget the drip for a while, that people that get into this vicious cycle of chronic recurrent nausea, a little bit of Ativan goes a long way in terms of just relieving that. And I think in part by relieving their anxiety over the issue, both the anticipatory part and the actual part of it. So
yeah, I agree.
We are at the bottom of the hour. Other questions for Tod before we transition to our case study here today?
One question. So for the, if you're recommending marijuana for someone, are you recommending getting guidance on dosage or leaving that to the dispensary that they're going to, or, just in general when they're starting out? Asha?
So it was, I don't know where you guys could hear David's question, but it was if I'm recommending marijuana, am I recommending a specific dose? Am I recommending a specific plant? And the answer is no. And I even would quibble a little bit with, am I recommending marijuana? I'm usually open to it. I'm open to the discussion on it. It's fairly uncommon that I'm actually really recommending it for patients. But for those of them who have expressed interest, I'm very open to it. And my usual recommendation is go to a dispensary, have somebody who's there talk with you about what they think in terms of dosings. More usually they'll have a specific plant or a specific recipe in mind. And then my usual recommendation is go a little bit on the low side to start out with, like we do with everything. Yeah. So does that answer your question?
Yep. Well, thanks again, Tod. Appreciate this. Great job as always. And for those who want to relive the moment, this lecture will be available on our YouTube channel in perpetuity. And so thanks again.
Thank you. Thank you very much.